I can't see question right now by the attendee, so we could uh, move to the next speaker and check the question at the end. So our next speaker is Dr. Wael Alshaya. He's a consultant neurosurgeon and spine surgeon. His main interest is deformity and craniocervical anatomy, pathologies. Dr. Wael has his training in Canada, and he had his fellowship as well. And he's working now in King Abdulaziz Medical City National Guard. So Dr. Wael will be speaking about the spinal cord anatomy at different regions and its blood supply. You may start, Dr. Wael. Thank you so much.
Thank you. Okay. Okay, can you see my screen?
Yep.
Okay. Okay, thank you for having me. So I'll talk about spinal cord anatomy, a different region with the blood supply. I know it's a very dry topic, but we'll make it interesting as much as I can. So this is an axial cut in the spinal cord. You can see, the gray matter, white matter of the spinal cord. And this on the other side, you can see the gray matter distribution is different from different cut to spinal cord. As the area with lots of muscles for the upper limb, you can see the anterior horn is larger. When you go to the lumbar area, that's why you have lumbar enlargement with lots of muscles. So you have the anterior horn also larger compared to the thoracic region. There's not a lot of muscle to supply, so you have a lateral horn is larger. So I'll go in detail describing the cross section. I'll try to make it interesting. I know it's a very dry topic. So we'll talk about the gross anatomy of the spinal cord, the microscopic anatomy, blood supply, and some clinical application. So as you know, the spinal cord diameter, it's less than 1 centimeter, and the length around 45 centimeters. There's two things only, gray matter or white matter. Gray matter, which is contained in the nerve cell body, and the white matter, the tract. It could be ascending or descending. And when you look at the spinal cord, it's a 31 segment. So don't mix it with the vertebral column. So there's 31 segment, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. All of them, they will give you a nerve, except the C1, there's only ventral, there's no sensory, and they exit to that area. And also there's 2 areas of enlargement, one the cervical between C5 and T1, and one the lumbar between L2 and S3. Because as we said, the anterior horn is large because there are lots of muscle to supply. So the other point we need to mention about the functional segment of spinal cord in relation to vertebral level. So for C2 to T10, you just, for example, if you have a lesion at T9, so spinal process of T9, which part of spinal cord will be injured? So you just add 2. So T9, that will be T11. And for example, this example, the T8 functional level spinal cord will be underneath T6 spinous process. So I hope, hopefully this is very clear. For the T11, T12 spinous process, it's for lumbar enlargement, and the L1 spinous process for the sacral segment of spinal cord. So that's really important for localization. And for the nerve root, as you know, the C1 nerve root exits between the occiput and C1, C2 between C1 and C2, C8, C7, T1, and after that, each one underneath the pedicle. So T1, T2, T1 nerve root, L5 is 1, L5. So underneath the pedicle, that you have the exiting nerve root. For the microscopic anatomy, so if you have cross-section and section of the spinal cord, you have gray matter, white matter. It's opposite to the brain. The gray matter usually out and the white is in. Spinal cord is the opposite. Gray matter divide the spinal cord to the different segments. So the gray matter, we have ventral horn, intermediate horn, and dorsal horn. And these will divide the white matter to different funiculi, anterior, posterior, and lateral. And the center can usually close in adulthood. So this is just an example to show you, cross-section of spinal cord. As we said, we have the anterior horn, posterior horn, lateral, and the funiculi, anterior, lateral, and posterior. So the anterior horn, we'll talk about some important information about anterior horn, some little bit about the posterior horn and the lateral horn. So anterior horn, it contains motor neuron, alpha, gamma, and interneuron. So only motor neurons. If you know that, that's good enough. And it's it's organized in somatotopic organization. That means more proximal, you will have more medial, it's proximal muscles, more distal, you have distal muscles. That easy. And the extensor muscles is ventral to the flexor. So if you know anterior horns, it contains the motor neuron, that's good enough. For the posterior horn, we have the secondary extensor neuron and interneuron. So its organization here is different. It's based on synaptic input. So the outermost, the more outer, it's exteroceptive, that means pain, temperature, and touch. For the deeper, it's two things, proprioception and the reflex. So you need to keep this in your mind, because when you go for localization, when you discuss clinical applications, it's really important. So the posterior horn, it's sensory, and two things, superficial for the exteroceptive, pain, temperature, deep, it's a proprioception and the reflex arc. That should be good enough to know. Lateral horn, it's autonomic pathway. So from C8 to L3, it's sympathetic, S2, S4 is parasympathetic. In the book, you will find variation. They will say T1, L2, but there's some variation. But C8 to L3, this is sympathetic, S2 to S4, this is parasympathetic. So we're done from the gray matter. We talk about anterior, posterior, lateral. Anterior is the motor, and motor neuron. Posterior, you have secondary neurons, which is, exteroceptive and proprioception, and the lateral horn, which is autonomic. So we're done for the gray matter. Now we'll move for the white matter. So there's ascending and descending. So lots of tracts when you read any chapter, but which one is clinically relevant? So for the most important ascending, two things you need to know: spinal thalamic and the posterior column medial meniscus. For the descending, corticospinal. So if you understand these, this is good enough. For spinal thalamic, we have, it's a primary sensory neuron and dorsal root ganglion. And dorsal root ganglion is very unique ganglion. It's just pseudo-unipolar. So there's only two axons. One go to the end organ, one going to the spinal cord. So usually you have multi-axon dendrites, but this one is unique. There's only two pathways, one from the organ itself and one going to spinal cord. And the synapse ipsilaterally to the dorsal gray matter, as we said, posterior horn, it's a sensory. So it should go to the posterior gray matter, okay? Then it will cross anterior to anterior commissure to going to the other side, to decussation, usually 2 to 3 levels. And as we said, either sacral fiber, it's a lateral, cervical fiber is medial. So everything in the spinal cord, more medial, it's more proximal, more lateral, it's more distal, the sacral fiber. So this is some importance. So if the patient has spinal cord injury, let's say at T6, okay? So the segment of the spinal thalamic effector will be 3 or 2 levels below that. So that helps you localization. The second thing is the posterior column. So posterior column decussation, for example, spinal thalamic, we say decussate 2 to 3 levels, but the posterior column, it will enter, same thing, dorsal root ganglion, going to where? To the posterior gray matter, and we say it's more deeper. The outer, the exteroceptive, the deeper, it's a proprioception. And will ascend to the gracilis and cuneatus. Gracilis, it's mainly for lower limb, which will be medial. Cuneatus will be upper limb, will be more lateral, okay? And the decussation for the posterior column, it's high up in the medulla, upper part of the medulla. And that's really important to know. So decussate through internal arcuate and going to the contralateral medial meniscus, and it ends up in the VBL nucleus and the thalamus. So the spinal thalamic, we said it will decussate 2 to 3 levels. For the posterior column, it decussates in the medulla. So it descends to gracilis and cuneatus. The other tract, which is the descending tract, corticospinal tract. So the corticospinal tract, it's coming from primary motor areas, premotor area, supplementary motor area, and sensory pathway, going through the centrum cerebral valley to the intronic capsule, down to the crus cerebri, then down to the pons, then we decussate lower part of the medulla. So majority will decussate, give you the lateral corticospinal tract. A small part, it will not decussate. Same thing we said, cervical will be medial, sacral will be lateral. So, and the last thing is the autonomic fiber. So autonomic fiber, there's not really a tract. It's all mainly diffused on the lateral aspect of the spinal cord. So the white matter fibers, we talk about spinal thalamic and posterior column, which is gracilis cuneatus, and the corticospinal tract, and autonomic. So these will be good enough to understand. There's other fiber robospinal, tictospinal, vestibulospinal. It's merely an animal study, but clinically is not useful to know. The other thing, the bladder function. So the bladder function, there is voluntary control and there is autonomic control. So voluntary control, it's coming from the sensory input from S2 to S4, which is pudendal nerve, going, same thing, dorsal root ganglion, going to the posterior part of the gray matter, then anterior lateral system, to the posterior column, to the center of the maturation, which is the frontal lobe and the pontine maturation center. And this sensation going to the brain, activate the voiding reflex, then it will go to the somatic motor neuron, to the S2, S4, to contraction of the pelvic muscles. And this will be middle bottom anterior horn. We said anterior horn, it's a motor neuron. So there will be contraction of the muscles. And also the lateral part of anterior horn, the onophonucleus, which contract the useful sphincter. There will be coordination between these two. Sympathetic doesn't do really much for the bladder function, and parasympathetic, it's mainly for the dorsal muscle. And that's helpful for localization type of a bladder dysfunction for this patient. So if the patient has spinal cord injury above S2, so that means will be disturbing of a descending somatic pathway and voluntary. So the somatic and voluntary pathway will be affected. If below S2 and affecting the nerve root, it will affect the somatic and autonomic or parasympathetic. Sympathetic really doesn't do much for the bladder function, so it's mainly somatic and parasympathetic. So if the patient has disturbed the voluntary function, the one controlled through the brain for the voiding reflex, the blood will be atonia, will be flaccid, so it will be something need to work. There will be spontaneous reflex that will be affect the dorsal muscles and give you neurogenic bladder. More or less, it will happen on the lesion below that, but it will be loss of the contraction of the dorsal muscles, and that will lead hypotonia of the bladder and then lead overflow incontinence for the bladder function. So same thing if you see cross section, so lots of tracts. So the most important thing, you can see the relationship of the corticospinal tract and spinal thalamic tract. So they're located on the anterolateral aspect of the white matter. The blood supply, so the blood supply of spinal cord, it's come from different part of the segment of the, aorta. I will come for that in detail, but it usually gets segmental. Segmental will go to spinal branches, ventral nerve root, going to the foramen, and it could be anterior or posterior, it depends. So if anterior radicular artery supply anterior spinal artery, or posterior give branches to the posterior spinal artery. So not all the spinal branches or radicular arteries supply spinal cord. So not all of them. Majority is, for example, for anterior spinal artery, only 7 or 8 branches. For the posterior spinal artery, it's around 12 to 13. So that's why some area will be vulnerable, where there's transitional region or there's border zone, there's less blood supply, especially between T1 and T4. An area there will, between the anterior and posterior medullary artery. As you know, the anterior spinal artery supply 2/3 of spinal cord, posterior spinal artery supply 1/3. So there'll be watershed area. Okay. So, sorry. Watershed area here, cross section of spinal cord. You can see the segmental artery. You have anterior and posterior segmental medullary. So medullary, that's when it's supplying the spinal cord. So to give you anterior spinal artery, which supply, as we said, anterior 2/3, that means supply the corticospinal tract and spinal thalamic. The posterior column will be supplied by posterior spinal artery. So that will help you for localization. And there will be, the sulcal artery, different branches on the spinal cord. Same more or less same what we discussed. So for the blood supply, for the cervical segment spinal cord, supplied by 4 branches: vertebral artery, bica, ascending cervical, and deep cervical. Okay. For the thoracic, it gets branch from thyrocervical and costocervical trunk, intercostal and subcostal. And the lumbar, there will be multiple branches from the aorta, and the sacrum from internal iliac. For the posterior spinal artery, supply 1/3, anterior spinal supply 2/3, and there will be watershed area between them. For the anterior radicular artery, as we said, it's less than the number, it's few. On average, it will be 8 to 9. That's why it's larger in diameter. That's why not all the segmental subspinal cord, but there's only few of them. So if you sacrifice one of them, there's high chance of the ischemia of spinal cord. Posterior radicular artery, which is larger in number, and 10 to 23, it's vary, and contribute only to 1/3 of the spinal cord. Venous drainage, it's more or less like arterial drainage, but there's no specific anatomy for them. So it's merely like a plexiform channels around the spinal cord. It's near the course of the arterial supply of the spinal cord. So they have anterior medullary vein and posterior medullary vein. They come together and form a trunk and then drain around the spinal cord to the epidural venous plexus. So we'll come one by one, some clinical application. The first one, Bronzy Cat Syndrome. So the Bronzy Cat Syndrome, they will have, just I'll explain each finding for these cases. So Bronzy Cat Syndrome, they have ipsilateral upper motor neuron lesion because they affect corticospinal tract, okay? Same thing, the patient will have ipsilateral lower motor neuron lesion because affecting anterior horn cells, okay? Loss of vibration and proprioception because affecting gracilis incuneatus, and the contralateral pain and temperature because spinal thalamic and decussate 2 to 3 levels below. So that's why everything will be ipsilateral except pain and temperature because they decussate 2 to 3 levels on the spinal cord. Complete spinal cord transection, everything will be affected. Central cord syndrome, it depends on the lesion. So which part affecting the central part of spinal cord injury? So you can see it with a hyperextension injury of the neck or a patient with the syrinx on the spinal cord. So small lesion will affect the pain and temperature. As we said, the spinal thalamic tract, it's cross anterior to anterior commissure. That's why the pain and temperature will affect initially. If the lesion expand in the size, so affect the pain and temperature, then it will expand to the anterior horn cell. That's why it gives you lower motor neuron lesion. So central cord syndrome, at the beginning, affect pain and temperature. When the lesion expanding, it gives you lower motor neuron lesion because anterior horn cells. When the lesion expanding, it gives you upper motor neuron lesion because affecting the corticospinal tract. That's clear. Posterior column syndrome. So posterior column, we said we have the gracilis incuneatus, and we have the posterior horn of the gray matter. So loss of vibration and proprioception, we know because gracilis incuneatus, that makes sense. Absent reflex because we said in the posterior gray matter, we have exteroceptive and proprioceptive. The proprioceptive, which is the innermost, it's responsible for proprioception and the reflex arcs. That's why reflexes will be absent, even if they don't have weakness. Okay, so they have loss of vibration, position sensation, and absent reflex. Posterolateral syndrome, which is affecting the posterolateral, for example, patient with the vitamin B12 deficiency, copper deficiency, patient with the bioneoplastic disorder. So it will affect the posterior and the lateral column. That's mean gracilis incuneatus will be affected and give you upper motor neuron finding because on the lateral part of white matter, you have corticospinal tract. So you shouldn't have lower motor neuron finding. And lower motor neuron finding affect anterior horns, but these affect the posterior, which is proprioception, lateral, which is upper motor neuron finding corticospinal tract. Anterior horn syndrome, which is affect only anterior horn, so they'll give you lower motor neuron, which makes sense. Combined anterior horn corticospinal tract, like for example, patient with the ALS. Okay, so it'll give you mixed picture, anterior horns and which anterior horn will give you lower motor neuron, corticospinal tract will give you upper motor neuron. So you have pure motor syndrome. So you see it in ALS, patient with the combined radiculopathy and myelopathy. So certain cases of mixed radiculopathy and myelopathy in the same setting can give you mixed picture. So patient have weakness and atrophy in the muscles, same thing, have exaggerated reflexes. So give you mixed picture. So you need to be careful, it's not ALS. Anterior cord syndrome, that's mean affect anterior part of spinal cord. So for sure, it affect anterior horn cells, lower motor neuron. Anterior cord syndrome, which is due to infarct of anterior spinal artery, which supply 2/3 of spinal cord. That means supply anterior horn cells, lower motor neuron, corticospinal tract, upper motor neuron, spinal thalamic, pain temperature will be gone, and autonomic, because we said it's located on the anterior lateral part of the white matter, diffusely distributed, or to be affected. For this patient, vibration and proprioception will be spared because supplied by posterior spinal artery. Conus medullaris syndrome, which is, it will give you flaccid bladder dysfunction because we said the bladder function mainly parasympathetic, which is S2 to S4. And the cellular anesthesia, because we said the more distal, you have sacral fiber will be located there. Questions?
Well, that was fantastic, Dr. Wael. This is going through this is like going through multiple calculations at the same time. It's the spinal cord anatomy. So we'll open for the panelists. We have time for discussion. Anyone would like to comment? I may start, Dr. Wael. You commented corticospinal tract is the obviously the main motor tract for the upper and lower limbs. Have you come across your review of any mention about the different kind of tracts that can go to the lower limbs in particular?
Lower limbs in particular, like only lower limbs, you mean?
Yeah, like I've come across references quoting the corticospinal tracts that's mainly to the upper limbs, while there are other tracts like rubrospinal or other tracts can supply or transmit signals to the lower limbs.
Yeah, so yeah, all of them is, you know, the corticospinal tract, rubrospinal tract, it's held corticospinal tract. So corticospinal tract is merely a flexor muscle tract. Rubrospinal tract, same thing. It's a flexor muscle tract. Vestibular spinal, tictor spine, merely extensor. But this is all more or less, it's an animal study. Like you don't find it clinically useful, like localization. You know, if you look on the corticospinal tract, rubrospinal tract, they're touching each other, so you cannot really separate. They're corticospinal, rubrospinal. Both of them, they do mainly, more or less, mainly affect the flexor muscles. So both of them are supplying upper and lower. As we said, more medially, it's the upper limb, more distally, it's the lower limb. It's like cervical, sacral, but not specifically for the lower limb.
Study an MRI for cervical spine. You have to study from the beginning, at least beginning of V2 till the end of V3, because most of the surgical exposure will be around V2, like in anterior CF. And V3, of course, it will be the posterior fusion or anterior fusion. So basically, I would say you have to study the whole length of V2 and V3 because it contains most of the variations. V1 for spine surgery, you don't come across it a lot. It's basically for cardiothoracic or thoracic surgeon. You have to study the branch of that gives to V1. And there is a triangle for V1. I didn't describe it here, but so again, in summary, you have to study V1, V2 and V3 from the origin to the end. I'm not sure, did I answer your question?
Yeah. So, so I think, would you recommend doing a CT angio, Dr. Jihad, before certain cases, or would you?
What I do in all cases that I'm gonna do for them craniocervical fusion or lateral mass, I do CT angio. Of course, trauma cases is a must, and what I do even in degenerative disease, I do CT angio. And this is very important in syndromic cases, Down syndrome, craniocervical anomalies. CTA, I think, is a must. But at least we have to look for the MRI. MRI shows a lot of findings. Sometimes you see the V2 tortuous loop, or you see the origin of pica. So I'd say I would study MRIs in all cases, CTA and posterior fusion, I will do it.